Dr. Virendra Agrawal with us from Dr. Virendra Laser Phaco Surgery Center, Jaipur. The patient is 65 years old female. We have planned for right eye cataract surgery with vision 3 by 60 and the cataract grade is NS3 plus cortical cataract plus PSC and the fundus is within normal limit. Over to Dr. Virendra Agrawal, sir.
Thank you AIOS and thank you UKSOS for giving me this opportunity to perform a live surgery. And I must appreciate the Drishti Eye Hospital setup is excellent and very smooth working. The staff is very, very cooperative and they know the job, so there is no hustle fussle. And because they have changed the total OT setup, so between the two things there is a gap, but soon we will cover up. टेबल का माइक टेबल फुट स्विच हाँ थोड़ा सा सलाइन डालना कॉर्निया पे माइक्रोस्कोप यूज कमिंग देयर
Can we have the microscope view, please?
Yeah, light को देखिए, light को देखिए.
It's a magnified view. Can you just put it to full screen? Can AV put it to full screen?
It's a picture-in-picture. You have to full screen it.
Microscope, sorry, saline, visco.
Okay, you can start, Virendra.
Yeah.
Can we make it full screen? AV team has gone for
Yeah,
that.
yeah.
So Virendra, start, please.
Yeah, just starting.
So Dr. Virendra, you'll be inserting a trifocal IOL for this case.
I am going to implant a trifocal IOL from a biotech. And as I said in the morning also, my first preference is that we should use the presbyopia correcting IOLs in almost all patients who are fit. Cornea visco. There are times when patients are not fit because of the topography, macula or some. Paracan. राधा किशन जी हिलना नहीं है, अभी सुन करने की दवा डाल रहे हैं, आपको हिलना नहीं है प्लीज. कोई दर्द हो तो मुझे बोलना है, नहीं तो हिलना नहीं है. And in that we एक बार डालो बेटा, है ना, we have bifocal, trifocal, and there are different lenses from different companies and EDOFs also. लाइट में देखना है, हिलना नहीं है, दोनों आँख खुला रखना है. There is no financial interest, but what I am seeing that the lenses which are bifocal or trifocal with the rings are performing better than actually the EDOFs at present EDOFs. Soon we are waiting for the other EDOFs to come. Light में देखो, पैराकेन डाला. अंकल जी हिलने से दर्द ज़्यादा होगा, इसलिए प्लीज हिलना नहीं है. दाई नहीं, प्लीज हिलो नहीं. कॉर्निया पे डालो बेटा, कॉर्निया पे डालो. एक वायल चेंज कर लो इसमें. नहीं, ये कॉर्निया पे आ नहीं रहा बेटा, तुम्हारा बाहर जा रहा है. नहीं, आई पे नहीं कर रहा. हाँ हाँ, पहले डाई बेटा, पैराकेन डाल दो कॉर्निया पे. अंकल जी कोई तकलीफ है तो मुझे बताना, लेकिन हिलना नहीं है. सुन की दवा डाल रहे हैं, आप हिलोगे तो सुन नहीं हो पाएगा. प्लीज हिलो नहीं. लाइट में देखो. Visco. I prefer to use bimanual, so I made a 2 side ports, and to have the maximum effectiveness and utility of the bimanuals, I make them 180-degree apart, and it becomes slightly difficult to do phaco in this manner, but I manage myself to do it that way. Usually the angle between the chopper and phaco need to be less. MBR. There can be some controversy. The people say triplanar, biplanar, uniplanar incisions. I prefer to make the simple uniplanar incision. It never gives me a problem. And I think what all we plan and do, that they are the triplanar or something kind of that. No, black one. The biggest advantage I feel with the MVR is that it goes in a manner the way we want. It is very predictable. 26. हिलो नहीं, अभी दर्द थोड़ी हो रहा अंकल। अभिकिशन जी, आप दर्द नहीं है ना? अभी दर्द है नहीं है? नहीं है, प्लीज हिलना नहीं है ना, हिलना नहीं है। This patient is having quite good glow, but I prefer to use the dye for the purpose so that we can actually see better. And in the new setup, though it is not a very new setup in the sense the best of the equipment is available, it is better to take the help of the dye. I am a bit slow surgeon, so please bear with me. I do. I have done removal of the some viscoelastic, so there is no increase in the pressure intralenticular and intraocular. And after that, we will be doing hydro. You can see the fluid wave has gone, and we can do the checkup of the free rotation is not there. It is not a free rotation, so we will do a multi-coordinate kind of video dissection. As the previous case, the discussion was happening that the hydro procedures are very, very important for removal of a cortical matter and the sticky material. Visco. Echo. Echo 1 power 30. Yeah. ये पकड़ना बेटा, इसको पकड़ना. So bottle height is just 50 centimeter. I usually use straight tip, but here I am using curved tip because that is available. देखो लाइट के बीच में देखना है, लाइट के बीच में देखना है. It is centered. I make trench first and then I divide and then I keep dividing. So it is not exactly divide and conquer. The vacuum is just 200. Nucleus is slightly soft, so I am trying to go more deep into it and create a plane where I can divide it. So I could make the two pieces.
I think the audiovisual team needs to get up and see what is happening.
Are you getting the feed there?
Yes,
we are
yes, now we're getting it. Please.
Okay.
So what are the parameters? Somebody can tell us. Nobody is telling us the
The
parameters.
power is 30, vacuum is 200, bottle height is 50, and flow rate is 30.
It's a slightly harder cataract compared to what we were seeing already.
It was looking more soft, so I kept the parameter low, but I am able to manage with the parameter, so I am not increasing right now. Because only a small part of central nucleus is a denser one, rest all is soft. So I try to make the pieces first within the bag, don't take out the piece by piece and then do phaco. There are people who try to create a space, but I think there is enough space. So this is how we can do the phaco within the bag of the pieces also. Otherwise you require to come out in the anterior chamber, in the iris plane, but we can do in the bag. So that is a basic advantage. I am using Signature Pro machine and you can see the stability of the chamber. There is no surge, nothing. Yes. Now I am shifting to phaco 2 where the vacuum is 450. नहीं ये काम नहीं कर रहा है. Yeah. So So now you can see the chamber is stable with the 450 also, and bottle height is still 50 only. So what I mean to say is that the bottle height requirement is not to be there for maintaining the chamber. It is the fluidics of the machine which works. And patiently you can remove the pieces are coming to the phaco tip. I am not moving the phaco tip. So this is how you can complete IA. Bimanual polish wala. Bimanual polish wala. Is it centered na?
It is centered.
राधा किशन जी आराम से हो, भी कोई दर्द नहीं है आपको, हिलना नहीं है, आँख में थोड़ा सा प्रेशर आएगा. Again the bottle height is just 50 for bimanual also, for irrigation aspiration also. Flow rate is 36 or Elone? No. Yeah. So as the discussion was happening in the morning that the pore size can be bigger or smaller or something, these are the bimanual cannulas designed by me, available with the epsilon. Again, no financial interest, and you can see the cleaning is good. You can do with this also like a coaxial, but I would like to change the hands and make it more comfortable. But bimanual दूसरे वाले देना है. So this is how you can do a irrigation aspiration easily. And as Sheetal was saying that you can do a hydro. So the biggest advantage of this that it keep on doing hydro whenever required. You don't require to take out this and do another cannula. And my irrigation line you can see is having a sand blast. So through this I can do a polish. And doing with the irrigation line, it gives you advantage of a rough surface as well as the irrigation as she was saying that the fluid hydro dissection and fluid polishing. So I am using the fluid pressure, I am using that sandblasted surface and keeping the vacuum and all other parameters like IA of 34 AFR and having the 50 bottle height and vacuum of 450. So you don't require to change the parameters again and again.
The connection is gone again.
And for trifocal, bifocal, CRV type of lenses, you require to do a posterior capsule cleaning beyond 6 millimeters, so you don't have a PCO. Initially, I was doing the same thing for the anticapsular, but later I realized that if you do anticapsular polishing, then the addition between the anterior and posterior capsule is delayed slightly, so I stopped doing that. Visco IOL. मैं कर देता हूँ, आप कर दो. लोडिंग दिखानी थोड़ी है, रूटीन ही है ना. अगर लोडेड है तो दे दो, नहीं तो मैं कर देता हूँ. So this is a trifocal lens from the Biotech. Biotech is a company for which I am using all their lenses, monofocal, monofocal toric, multifocal, trifocal and all other lenses. I am happy that Indian company is giving a very good lens in the market at a competitive price and big advantage to the patients who can't afford and unnecessarily probably not required to go for higher price. Usually I don't load, but luckily I thought that we should show it, so that's why we have done. You can see that the smooth movement of the plunger. I'm not that expert, so the anterior loop is coming straight, is not coming that folded, but still it will not have a problem because the lens material is very soft, it will not create an issue. I prefer to do a implantation with the cartridge going in through the incision rather than pushing through the incision and making the incision ragged. Irrigation line. Irrigation. And I prefer to do this rest part of the implantation with the hydro itself. इसको irrigation line को change करेंगे बेटा. कैनुला जो है ना irrigation वाला. I prefer to use the sand blasted one before IOL implantation and after implantation, I change it to plain. वो वाला सही था पहले वाला. So again with the bimanual you can remove the visco very easily in front of the IOL and behind the IOL. You can just nudge the IOL, go behind with the irrigation line, keep aspirating anterior to it. So there is no risk of doing the capsular cut as you can do otherwise with the coaxial. It doesn't mean that the coaxial is bad, but I prefer that the bimanual is an instrument along with the irrigation aspiration cannula for maneuvering many things into the eye whenever required. So this way it is a big advantage and we can do a complete cleaning.
So I think that was very nice, Virendra. Thank you so much
polite
for
man.
your excellent demonstration of the case. Can we move to the next case?
Yeah, easily.
Yeah,
Thank you once
thank
again to the AIOS, UKSOS and particularly Dr. Namrata and Dr. Gaurav for arranging it so well.
Thank you.
So well.
Thank you.
Thank you.
I must appreciate the effort goes behind managing everything, but they have done flawless. Thank
So,
you.
Thank you. Thank you, Virendra. The next
Well
case is
Just
going to
show
be...
one thing for 1 second that I treat even the side port like a magnesium. I do hydro from both ends of the side ports also, and that prevents many things and don't require to have a higher pressure to close the wound.
So
Thank you very much.
Thank you.
You
Thank
can
you.
shift